Hi, I'm Becky Sanders, and I'd like to introduce and welcome you to the National Telehealth webinar series. For our October series, we are going to hear from the South. Our webinar today is hosted by the Southeastern Telehealth Resource Center and Lloyd Sermons. And this is one in our series. Every month we do these. And with all of the telehealth resource centers around the nation, and Michael, I'm going to need to ask you to choose the next slide for me. With all of the telehealth resource centers around the nation, we do have 12 regional telehealth resource centers here. You see the Southeastern covers Georgia, Alabama, South Carolina, and Florida. And we have 2 national centers as well. One covers technology and the other policy. Advance the slide. So just a couple tips and notes. Your phone or computer has already been muted. We will reserve time at the end for the Q&A, as I mentioned, and we will send a link out via the chat function at the end for a post-webinar survey that helps us if there's topics that we need to cover and to always be on top of our game. We are recording today's session, as I told you, and there's the link where it will be posted. We will also send out an email letting you know when that link is posted. Next slide. So without further ado, I'm going to introduce Michael Murphy and Rosetta Roberts. And our title for today is Telemedicine with a Southern Accent, Addressing the Rural Healthcare Crisis. Michael?
Thank you very much. We appreciate it, Becky, and we thank Lloyd for inviting us in from the Southeast. As you can tell, we do have a true Southern accent rolling in here. So myself and Rosetta Roberts, who is our clinical director, will be presenting a little bit of information today on how we have used telemedicine services in a very rural and poor state. So we thank you again, and we hope it'll be helpful to everyone who's participating. A little background, what we are, Medical AIDS Outreach of Alabama, is a program that we're based in pretty much the southern part of the state of Alabama. We are covering about 28 counties in the state, and our primary mission has been HIV/AIDS specialty care, in which we do everything from the primary care for those individuals living with HIV, but we also have a variety of social services and programs that we offer for them and also for their loved ones. We have begun to increase our access to care options to include hepatitis C testing and hepatitis C treatment. We've been doing with comorbidities for a while, and now we've opened it up to individuals who are not living with HIV, who are hepatitis C only. And so we've been able to increase our process, and using telemed as a primary part of that too. And we anticipate we'll continue to increase our use of our model to do other medical issues that are not HIV specific or related. So today what we really want to deal with is some of the disparities in access to health care that we have seen in rural settings. And this is particularly geared toward Alabama, but I'm going to tell you, based on my discussions with people throughout the country, I have seen individuals who are in rural areas in the Midwest, in the Northwest, and other parts, and they are experiencing very similar issues. One of the issues more in the Southeast is just that our poverty levels are so high. Sometimes that makes it a little more difficult, but I think what we're going to talk to you about can be used in rural settings anywhere, and in fact could be used in urban centers. I've talked with individuals who are in LA County in California, and it is such a massive county, and transportation is such an issue that I think certainly telemedicine care for HIV specialty is a real option, particularly if you're looking at individuals with different language issues, where you could possibly link a provider with a certain language to a consumer who has a specific language need. That could be useful. We're going to talk a little bit about the Alabama eHealth model, what that means and how we use it. We're very different in some cases because we use a direct practice model. We actually do full-on medical care using peripherals that we have found has been useful, and we'll discuss that a little bit more. And then we will talk about how we use it in transcending the rural healthcare barriers, because there are some unique things for rural areas when it comes to healthcare, especially in poor states. And then lastly, we will talk a little bit about the challenges as well as the benefits on using telemedicine services to do this care. So in Alabama specifically, there are 4 things that we've really found as we've been practicing now. Our agency itself will turn 30 years old in 2017. When they first began their process, they were doing mainly social service care, particularly respite care. Well, now what we have is that we're serving a full medical care process, mainly because no one was really able to do it. We used to have consumers, when I first started as a part-time social worker, individuals were traveling in some cases 2.5 hours one way to get basic care and then returning back. Before our clinic, even our first clinic started, they were traveling 4 hours one way and 4 hours back. So you know, retention in the care with that model back in the 90s was probably not the best. But we've been dealing with an increasing number of HIV diagnoses, new diagnoses, and that is a common field that we see a lot in the South. But we are seeing new diagnoses when we were hopeful that we would not see any new diagnoses. Poverty levels in the Deep South particularly are high, and we'll discuss that more in a second. We also will talk, and I'm very glad to have Rosita with me, to talk a little bit about the health professional shortage that we're dealing with in Alabama. And as you will see in a moment, that's fairly strong. And then the stigma, or if you can use a better term, just the prejudice that still exists around certain healthcare issues. And HIV is one of those issues, and we'll talk a little bit more in depth with that. So many of you have already seen this slide, I'm sure, but this is a general overview provided by our friends at AIDSview.org on the impact on HIV and rates of diagnosis by county. And as you notice, we still have those pockets in certain parts in the Northeast and out on the West Coast, some areas in the Midwest. But if you notice this very dark centralized area in the Deep South, it is reflecting, unfortunately, this transition of the South being this epicenter of HIV, particularly new cases. What we know is that certainly we have the most HIV cases on new diagnoses, but we have now bypassed other regions for most cases overall. What we do worry about in the Deep South is the fact that our morbidity rate for people who are living with HIV and the AIDS diagnosis is higher than the rest of the country. And that, again, is directly linked to some of the limits of our healthcare infrastructure in the Deep South. In Alabama, we cover an area from that central location. If you notice on the screen, we have 3, those darkest of counties are those with the highest rates. And those 3 counties in the center of the state are the counties that we sort of begin out of, but we cover pretty much all of the southern part of the state with the exception of the 2 large counties that are on the Gulf Coast. We're in those areas providing the care. As you notice, we had an issue related at the end of 2013 of the number of cases of people who are known to be living with HIV. The issue at that time, too, was the fact that 45% of those had progressed to the AIDS diagnosis. So we're close to half the people who are living with the HIV diagnosis actually are also living with the AIDS diagnosis, which is difficult. We also further see the estimates in regard to how many could be positive, and that is an issue that we are certainly concerned about, because we have to get in and test individuals out in these outlying areas, and we got to reach people at high risk, and that's a big issue for Alabama, among other states. This gives you a little bit of feel about the demographics. If you notice on the screen, we have individuals that on the blue line represent African American or Black males. In Alabama, you can certainly see the disproportionate impact currently on those individuals. We've seen that as a trend for many years, and that has just gotten worse. We also, as you notice, among our African American and Black women, it's been a up and down scenario between our African American consumers in the state and also our Caucasian males. And then we see on the lower line, Caucasian females. We do not have any data regarding individuals in the Hispanic community on this state numbers, but we will show in a minute on some items that we were able to pull together that'll give you a reflection on that. Demographically, to give you another impact of what we're dealing with, about 27% of Alabama's population identified as African American or Black in 2013, according to the U.S. Census Bureau. 71% of the new diagnosed cases during that year reflect individuals who are African American or Black. 63% of all persons living with HIV in the state of Alabama are identifying as African American or Black. And if you look at the two screens, the two items here, on the left-hand side, if you face your screen, you're seeing the Alabama state population. On that one, you see that Caucasians or individuals identifying as white in the blue represent the larger portion, and then the next largest significant demographic are African American and Black communities, with the Hispanic Latino populations in that green. You flip it and look at the HIV/AIDS diagnosis and the demographics, and you almost see a mirror image. It's a jump, but this time it's indicating that how disproportionately impacted African American and Black Alabamians are at this point. And that is an issue certainly that we're having to really look at strongly in our state. Just to throw as a side note, in South Carolina, just to show how it's not just Alabama, they almost show the exact same issue when it comes to, in 2014, the populations of South Carolina demographically, and then those who are being disproportionately impacted by HIV/AIDS. And as you can see, African American and Black communities are being disproportionately impacted. The recent trends that we've seen through the years is that we have seen an increase in the number of HIV and AIDS cases in Alabama. As again, you notice, the problem here is that we have continued to see a disproportionately large number of the folks who are being identified or living with the AIDS diagnosis. This is also, in some cases, we have people coming to our clinics, and we currently are operating 12 clinic sites that are coming in sick and have already reached that diagnosis. So it is a healthcare crisis still here in 2016, and these were reflecting numbers through 2013, but we have not seen that improve. The other piece that we've got to address is poverty. If you recall in the other slide, when you talked about when we looked at those counties that had the high rates of infection, they were mainly in the southern part of our state, and that they were in areas congregated around the southwest, southeast zones. Well, that same overlay, if you looked at it, reflects the poverty rates in Alabama. For those of you in the healthcare field, you know that's nothing new. Poverty and poor healthcare outcomes seem to go hand in hand for a variety of things. When those same counties they're experiencing, what we're seeing is our HIV numbers are following that same counties with high poverty rates. In Alabama's 67 counties, we have 46 counties with poverty rates that are higher than the national average. 23 of the counties have poverty rates about 20% above, and then 5 counties have poverty rates above 30%. Wilcox County, which is listed here, has one of the highest poverty rates, not only in Alabama, but in the United States. And we also have Lowndes County next to it that also has increased in their issues. So we're dealing with a very poor state in which 1 out of every 6 of Alabama's residents, and we're almost 5 million, live below the federal poverty line. So this, I think, truly is contributing to not only the HIV, but also Hep C increases and other issues that are going on. Let's add one more piece to this, and that is health professional shortage areas. Alabama, again, has 67 counties. 62 of those counties are either partially or wholly considered health professional shortage areas, meaning they do not have enough, not only MDs, but also nurse practitioners or PAs in that county to adequately cover the population. And we're not talking just about HIV or specialty care, we're talking about primary care. And this is a huge issue. This is why we, again, Alabama, unfortunately, we're great in football and seem to be doing great there, but we are high in every poor healthcare outcome. And then, unfortunately, we're always located very low when it comes to the strong points. And that is an issue that we, again, as providers in this state, are having to look at more clearly. Our HIV treatment centers are often located in urban areas, while what we see are that new infections for HIV are increasing in the rural counties. One of the most telling signs came out that we were looking at where HIV was centered. And we certainly have Jefferson County has the most number of HIV cases, but Montgomery and other very rural counties actually had the higher rates overall. Well, why that's a problem is that if you look at more people and the number of people living with HIV and AIDS in the state of Alabama are actually located outside of those big metro areas. In fact, about 65 or more % of the men and women and young people living with HIV in Alabama live outside of urban areas. They're in small towns and in very rural areas. This is a trend that we see a lot in the South, and it's very likely going to continue to increase in other parts of the country, especially as we see heroin beginning to increase, because we've already seen it here. We know the Midwest is already dealing with it. Some other areas have been dealing with it even longer. And a lot of those places in the South and in the Plain states and others are in rural areas, which means fewer resources. So we're going to see an increase in HIV and I believe Hep C as well. And then one last piece to note. Transportation, and those of you who do any kind of care or services in rural areas, this is certainly an easy statement to make. If you look at Alabama, we only have 5 counties out of our 67 counties which have a full-time public transportation system, meaning mainly they're in metro centers, so it's not really covering the rural areas. And by full-time, those are going to end at night. They're not a 24-hour. That means all those other counties either have a call systems rural healthcare transport, which is very limited hours, or they have nothing, in which they depend on other people to get them to places that they need to be, particularly healthcare. So in Alabama, then, we look at our telemedicine as being an option that could go into those areas to provide better service or any service where they've got barriers. I'll add one other piece here. In Alabama, we are struggling right now, too, with the fact that we are having a hard time keeping our Medicaid program going. We were one of the states that did not expand Medicaid services, so we have a large uninsured population in Alabama. And then we even went further to almost not fund Medicaid, which thankfully our legislature did respond recently to at least get it funded. The problem with that is county hospitals are struggling, and in many cases, community hospitals are already started closing. That is not going to help rural health care in our state, and it's not going to help rural health care anywhere in the United States. So we are looking at that telemedicine option as not only just helping with our patients, but also we're working with other collaborations to maybe look at how we can link in with these rural hospitals to keep them going. So with this in mind, I'd like to talk a little about what we look upon as telemedicine and what we do as a direct practice. And with that, I'm very happy to have Rosita Roberts, who is our clinical director, who can share with you a little bit about this. I'll give a little promo too, that Rosita is an RN, but she's in the process of becoming a nurse practitioner. So she's going to really be addressing this as a medical provider of care in this state, because thankfully she's going to stay in Alabama to do her practice, so we appreciate her. Rosita?
Thank you, Michael. I've been a nurse for about 25 years, and telemedicine to me has been one of the most innovative ways to provide quality health care in some of these rural poor counties that we serve here in Alabama. Telemedicine, as it says on the slide, is just a video chat environment between a doctor and a patient. The difference with telemedicine and teledoc, in my opinion, is that we actually use the peripherals to actually in real time listen to heart sounds, look in the ears, look in the mouth, and check the throat, and we can also check skin lesions, take pictures of it, and upload it to our electronic medical record system. In this sample here, this is a nurse who is in a rural clinic with a patient, and she's using a peripheral that we call a dermoscope. And the dermoscope allows Dr. Beck, who's seen on the video screen there, who's in the Montgomery home office, seeing this patient in real time. He's able to look at a skin lesion, ask the nurse to blow it up, and we can take a snippet picture of it and upload it to the EMR and send it to a outside referral source or a dermatologist even if we need to. Again, this is all in real time. We have the ability to record cardiac sounds if we need to. If we find a patient that maybe has a heart murmur and we want to send just a strip to another physician, we can do that through the use of the telemedicine. It all is operated through the Bluetooth. It is totally secure. And more importantly, it has drastically allowed us to cut down on the amount of travel time that we used previously to be able to see our patients. Next slide. This is just another picture of our telemedicine in action. Here's a picture of our doctor, Dr. Bat, who was in the Montgomery Hub office video chatting with or using the telemedicine system with a patient in Selma, which is about 58 miles from the Montgomery office. And on his screen, he's able to see the heartbeat once the nurse uses the Bluetooth stethoscope. He's able to record that. He's able to ask the nurse to change the position of the stethoscope or to ask the patient to move to a certain location or change her position so that he can get a better sound or quality. And you can do that all through the telemedicine system.
Rosita, can I ask you a question?
Yes.
Now, when you are doing that, because you've served as a nurse on some of those occasions, how fluid is that? Do you find it difficult as a nurse when that's occurring? As
a nurse, it is very fluid. We like that it is in real time. Those instruments are high quality. Actually, I have purchased a stethoscope to use in a hospital setting because you have the ability to control the volume. You can turn it up, turn it down. It's very clear. Our patients really like it. In the beginning, we thought that they would be apprehensive about appearing on a television screen. However, we found that our retention rates have really stayed high in these rural clinics because it's just something about the convenience of being able to go 20 minutes versus 2 hours, and you still have the nurse that's providing the hands-on interaction with the patient, and they still get to see the doctor a lot more. They feel more comfortable conversating with that physician over the video chat versus seeing them in person.
So one of the things I know I get asked a lot is about, like, so what did we do before this? And one of the reasons we kind of came up with this whole e-health concept under the Alabama e-health model was because we originally were sending out staff members in a van similar to this one. I know I started off as a social worker, part-time social worker with the agency, so we'd climb into a car and we were going. But in your case, you were also a part of a van group, wasn't it? So who all was with that?
Yes, when we were lucky enough to have funds donated so that we could use a van. And oftentimes we would arrive to the office most times at 6 in the morning because our travel time to most clinics were as little as less than 30 minutes, as much as 2.5 hours. And a lot of that was based on traffic. We would take a medical assistant or a phlebotomist. We take the nurse, the physician, a social worker, as well as a receptionist. And as you see in the back of the van at the time, we would load up our charts. We'd load up a centrifuge, vials for drawing blood. We would take all of the medications. If patients were receiving meds from us, travel in the van, get there, you have to unload it, take it out, set everything up. And unfortunately, you were only able to see maybe 4 to 6 patients because you spent as much as 4 to 6 hours trying to travel to and from. So, and back in those days, it was difficult because we could not see patients that just routinely came in sick. If they were not scheduled, unfortunately, we couldn't see them because the chart was left in Montgomery. We only took the charts for the patients that were scheduled. So it became hard and inconvenient to offer simple emergency care because you didn't have the medical record or other supplies designated for that particular patient.
And I know from my perspective, even, both as a provider of some care, but also as an administrator, is the fact that we were not able to see as many patients, and that we were not able to, almost if a patient missed that appointment, they were not going to be able to see us again unless they traveled a long distance until the next month cycle, which was not really good for retention into care. But I also just often look at it administratively that I am traveling and I'm sending a group of 4 to 6 staff members, including a physician. I'm paying people to ride in a van or paying to ride in a car. They're not seeing any patients, so there's no billable time. And so therefore, we're paying a lot of money out and not serving the consumers we really need to be serving. So I think that when we first started looking at the telehealth model and using an Alabama eHealth concept, that first time when I even remotely encountered it was as a mental health provider. I knew that mental health was using it in regard to psychiatric consultations with community mental health centers throughout the state. And I thought that would be wonderful if we could figure a way to do it. And not too long after that, back in the early 2000 period, we began to see peripherals. I would see them at conferences, and I knew this could be an answer, particularly for more of a rural state. So this is good. There's a lot of memories in that van now.
Yeah.
And this is a little quick note. When you look at Alabama, we are a beautiful state, in my opinion. We are a very poor state. But this is an example of where we might be going. Now, this happens to be a very famous road. This is the road that runs between Selma, Alabama, and Montgomery, Alabama. And for those who may be aware, this is where the civil rights march from Selma to Montgomery occurred back in the 60s, which not only changed Alabama, but changed the country and really the world in many ways. And we find this very good to the standpoint that as this bridge, we now cross over because we provide the medical care for consumers in that area. We work collaboratively with a group called Selma AIDS Information Referral, and they do the social work services for that particular region and do an excellent job, and we do the medical care. So what we always talk about is the fact that we see telemedicine making that same monumental change in a very rural, poor area, that it changed the whole concept of what rights were in the 60s. We're doing the same thing for what rural rights could be for medical care, that people in rural areas should have same access to the things that they get in a normal urban area. So let me talk just real quickly. When we looked at this in the beginnings, we had a telemedicine beginning, had a spoke concept. We worked collaboratively with 2 other organizations, which are good friends and good sister organizations. We were with Thrive Alabama, which is in the Huntsville area, and they worked with us on this particular grant. We did a National AIDS Fund grant to start off with, and they were looking at linking a program in the northwest area called Florence with Huntsville. We also worked in collaboration with a group in Tuscaloosa, Alabama, Watley Health Center, which is a federal clinic, and they were doing HIV specialty care, and they wanted to link a program in Sipsey, Alabama with their main Zoom, and then we were looking at from Montgomery to link into Selma. So that was the very beginning. We were using this encrypted high-speed data even for that point, really got it off the ground, and then we're using all sites to try to begin that mindset of how to use it. Dothan was one of our larger areas, and that was one of the next area that we started going with a satellite site. But then we became one of our hub sites. And currently, this is an example here in Dothan, Alabama, in the southeast corner, in the area they call the Wiregrass, that became a stronger hub for us to do the care for that region. This particular was a Chamber of Commerce visit to our new site that we opened up there. And we were very glad to have great support from the folks in Houston County and around that area. An area thing that you'll talk about in just a second, and that is for a program like this to work in rural areas, it really needs to involve great partnerships. And one of the things that we were very fortunate is we have wonderful relationships with our federally qualified health centers, our 330 clinics in the area. Those were the second areas we began to expand out to. And I know, Rosita, right now we're operating on several, but what have you found with your relationships with those federal clinics?
The federal clinics have been some of the most supportive we've seen yet. They provide the space for us. They don't mind us using an exam room. They work with us as far as checking in our patients or making our patients feel comfortable and a part of their clinic as well. So they will assist us in getting our patients to the back, and they very friendly, non-judgmental, confidential environment. And we're able to house our equipment there on a month-to-month basis. And it has just really worked out well. We operate within their time frame or business hours. We're able to see more patients because of their help, because we can arrive 30 minutes prior to setup, and most times they've already got our patients kind of checked in and gotten a row ready for us, and we spend less time traveling and getting set up, thanks to us being able to keep this equipment in their facility.
And the main group in that area is a group called the Southeast Alabama Rural Health Association. And they're really good. They were one of our first FQHC partners, and we actually have equipment in, is it 2 or 3 sites?
We use it in 2 of their sites. And one of the things that has really been instrumental for them, because they're an FQHC organization, they also serve a lot of underserved population. And they are now able to link patients that are HIV or Hep C infected directly into care with us. So that has decreased the burden of those physicians having to provide the specialty care. So that has really increased, and it has really been great for our partnership with them.
Excellent. And so now this is where we are. When we begin just from our zone, our partnering organizations are still using their telemed in their zones. But we began to expand rapidly out of our just hub site of Montgomery with one link to Selma and then later to Dothan. We actually now have 2 hubs. And that's one here in Montgomery, Alabama, one in Dothan, Alabama. And then we are linked to 10 other sites. Part of that has come from adding another FQHC. I think that's Health Services Incorporated, is that correct?
Yes.
And then we also expanded in 2015, particularly and into this year, with programs with the Alabama Department of Public Health, which has been a great relationship that allowed us to have public health sites in some very rural, isolated counties using their broadband. So again, it's really all about working together when you're in a poor state or you're in a poor region, collaborating with a lot of folks and everybody bring their strengths to the table. And that's made a big, big difference on the success, I think, that we've been able to have in our systems. So now let's talk about, does it work? And I think one of the quickest notes to say is we are serving right now around 1,600 to 1,700 patients. And a quarter of those patients now are telemed patients only. Now, when I say that, we have a quick proviso here, quick note. Every patient has a right to see a provider in person. We would never limit them to that. What we are able to do, though, is to, because of the telemed structure, see patients easier, more frequently, rather than, because the provider will go down to our sites, and particularly they go down to see that patient for their first health and physical. That's what we require. But after that point, they have a right. And I think what we see now is all the patients that we are seeing in those zones have chosen telemed, haven't they, Rosita?
Yes, they have chosen telemedicine, and it has also been a great resource for our providers for coverage. If we have a physician that's out, right now we have a nurse practitioner on our Dothan site who is in Ethiopia providing HIV care for a mission trip. And so the providers here in Montgomery, which is about 200 miles away, we're able to continue to see those patients for sick visits or regular routine visits while she's out. And they can continue to go to that Dothan office and still see a physician from the Montgomery location.
And you know, one of the things, we're very fortunate, we're involved with AIDS United, which used to be the National AIDS Fund. They've been great partners with us too. And they were able to link us up to an evaluation component with Johns Hopkins University. And one of the things that came out of it, was really an assessment on patients and their feelings about telemed, because that's always the issue. Because we are very conscious that our consumers have to be comfortable with whatever is being presented. So if the telemedicine service delivery model is not for them, we would never force that. But what we have found is that most of those patients have said to us that the technology was really not destructive at all, and that they really didn't see it that much in a difference in the traditional care. They didn't see it as negative as we thought or afraid they might. So we did early evaluation, and we haven't got our data back on the last round, but under that initial survey among our consumers, we saw very minimal concern about the telemed care. We saw over 90% of the consumers that were polled or brought in reported being extremely satisfied with their telemedicine service. We also saw realistically what was happening. That's 95% of our consumers have been virologically suppressed, meaning the virus is at a rate so low that honestly their health care is going to be great. And as an additional help, they would not really be able to infect anyone else should their virus, their blood, or other fluids impact someone, that it's so low that they're no longer at risk of infecting other people. That's huge, because that's what we call treatment as prevention model. So more people we get into care, the better they will be able to live, but they also, as a great side benefit, are not infecting anyone else. And then also at that point, we saw about 94% of the consumers who were telemed were retained into care. And based on preliminary data, that's going to be higher, that we're seeing those consumers that are coming in much more regularly. They actually, our telemed consumers are more reliable to come in than honestly our face-to-face consumers that we're seeing, which is fascinating. And there's some reasons, I think, behind that. Anything you want to mention before we go to legal, Rosita, about that treatment piece?
No, and if you have patients that are leery about doing it because they're afraid of seeing themselves on a big TV screen, it's really minimal, because they'll see the provider more than they'll see themselves. And so we've actually had patients that see that as their day to dress up. They feel like that's their American Idol day. So they actually enjoy the telemedicine opportunity. So it's just really been beneficial to our patients.
And I think also one of the things with consumers, and especially rural people, because I grew up in a rural area, Rosita, you did too. Mm-hmm. My grandparents are rural. It's hard to get rural people to the physician because the fewer access points and the more obstacles, they just won't go. Mm-hmm. And you know, one of the best pieces is to have more options, the most options you could possibly have. So I really see the telemedicine services, and it's bearing out in the data now, are really showing that this is a really viable option, not just HIV, which is really a heavily issue, and it's a very stigmatized issue, especially in rural America and in this deep South, but also any healthcare issue. Rural people particularly could benefit from this option, and the more we think it through and we can establish kind of some models to use, I think the better. When you look at legal considerations, I think first and foremost, one has to look at the HIPAA compliance issue. And one of the best pieces is that this is a very HIPAA compliant program. We always ask for and respect is to get business associate agreements with any place that you have a unit. So at the FQHCs and at the health department, we establish a good business associate agreement that we are sharing with them and they're sharing with us, that we're all secure in that point and we all have a clear idea of what our parameters are. We also have questions about internet security, and we have actually a really good opportunity here to get one extra piece of information. My IT director actually just have to walk in, and his name is Billy Sample, and Billy's been a great asset in this whole growth of this model. I'm going to ask Billy, if he doesn't mind, to speak real briefly on how we ensure the internet security process. Billy, do you want to share?
Absolutely. Thank you. The way that we protect our internet connection here, not only do we have a firewall in place, but we also have a device that we have purchased that acts as a gatekeeper. What that gatekeeper does is anybody that tries to access into our network to place a video conferencing call through our telemedicine equipment, you actually have to know a couple of key pieces of information, and without that information, the gatekeeper will deny you access. So it's that one added security protocol. The second thing that I decided to do was when we created our telemedicine network, we wanted it to run on a different network than our standard internet traffic. Everyone is always concerned about their internet getting hacked, and when we started talking about the liability of having a video conference, I wanted to make sure that we actually added an additional layer of security. So our internet traffic runs on one pipeline known as a subnet, and our telemedicine traffic runs on an independent pipeline as a separate subnet. what that allows us to do, as Mike has already described, that we have several locations that we actually provide telemedicine in. We've created a wide area network that allows all of those telemedicine networks to communicate with each other like they're in the same building. So it definitely improves the reliability and the quality of the video calls that we do when we provide telemedicine. I'm very excited to say that we have definitely been able to see some increase in some broadband availabilities in some of the rural areas. We have seen in Barber County specifically, they were able to really improve that county's infrastructure to provide additional broadband space. So as you guys are considering the possibility of telemedicine networks or expanding what you may already have, please understand that the internet security and the broadband are a huge piece that you've really got to look at in the beginning as you start your process of moving forward.
Great, thank you, Billy. Rosita, I'm going to ask you to talk just a brief one about the electronic health record, because that is always a question people ask me about when I'm doing programs. So how does that function within the telemed system?
Within the telemed system, we generally use a laptop, and because our EMR, electronic medical health record, is web-based, we're able to access the EMR from the laptop, and we're able to document in real time, which is very HIPAA compliant, and it is also secure.
Excellent. And do I'm understanding that also it can capture pictures and
yes,
stuff immediately?
If you have an EMR that will allow you to upload documents or snap pictures from the peripherals that you have, that is a very viable option. We can use that if we need to. If there's a lesion that we need to take a picture of and upload it, we can do that and attach it directly to the file of that particular patient.
Excellent. Last thing I'll make note on here in the state telehealth rules. One of the things you want to look at, each state will have different concepts of how telehealth and telemedicine can work. Alabama actually allows us to do this direct practice within certain parameters, and it's been functioning well. Took a while to get the Medical Association for the state of Alabama, but at the same time, it's worked really well. They can't complain. They actually have seen the benefit, and it's going to a broader model, I think, here in the state of Alabama. I'm not going to really dwell on the Sherman Antitrust Act, but this is just something I ask you to look at. It's not been an issue for us, but there's some things in, and you'll see these. This presentation will be on where you can access it. You may want to research it a little bit. Just that primarily looks at competitive models and preventing of monopolies. I don't think that's really going to impact us in telemed, but it could. So I just ask you all to do a little research on it just to make sure that in your area that this is being addressed. Again, business associate models are good. You want to get that in regard to HIPAA. You also want to have those business associate agreements with any collaborating partners at a patient or remote site. In the internet security we've already talked about, just make sure that you've got business agreements, associate agreements for any IT support that you have with individuals who may have access to PHI, the public health information. Make sure that you do have the encrypted connections, that's an absolute. And it's been, as Rosita said, looking at those different electronic health records, because if you're going into the telemed piece, especially for direct practice, that's going to be a huge benefit. The software piece that we've already talked about, and the encryption model, we actually increased from one of the earlier slides. We're using an even stronger encryption now. One last quick statement. People ask me a lot about the insurance reimbursements. In Alabama, at one point, we still don't in Alabama have a particular parity law. Some states have initiated those to where telemed services get a parity amount as you would see if you were seeing the person face to face. Alabama does not currently have that legislation, but one of the great things is that we have seen the larger health insurance companies in Alabama, as well as Medicaid, give us parity on this. The last large provider on the insurance did that just this year. That's been good. It helps us a lot in what we're doing to know that we are doing the same care and we've got the results. We know that based on our data, but it's also extremely helpful to know that we can get reimbursed for it. As Medicaid, as I mentioned, they've got certain limits. We have the eligible technologies being covered. So look at your state, be thinking very much about the different options in there to make sure that if you're using it for direct practice, that it's going to be covered and more that you can get reimbursement for it. So that's our information. We are very happy again to have this opportunity to really share a little bit today. We wanted to stop in time for any kind of questions that may come up, anything that you may want to ask us. I will certainly ask Becky or Lloyd to handle that process if they won't mind, and we will go from there.
There are two questions, Michael, and you or Rosetta can answer, I guess, as you feel best. Both are from Luke Kistler. The first one I'm going to go ahead and throw to you. It says, has MAO considered any home-based follow-up care for patients that have access to internet and, of course, a PC or phone? And he does give an example, maybe a patient that virologically suppressed and you know, they have access, follow-up care. Is there any way, have you guys thought about maybe trying to move into reaching the patients at home?
Good. I can start that answer, and then I'd like for Rosita to follow up, and then Billy can give a little bit of techie input on that. From our perspective, definitely. And I tell you what, we're looking at it. We would love to see it, particularly in our retention to care and our linkage to care concepts. If a patient's been out of care, I would love to have a social worker or a nurse, community-based, that could maybe go and visit that consumer at their home. And with that in mind, being able to do a quick note or assessment. And I even think to a point that if they had an issue, to be able to link them back in to the main offices, the hub sites, maybe even giving them a chance to say hello and meet their physician, just to establish the relationship. Because with rural people, it's all about relationship. People want to know who they're going to be talking with, and sometimes that can get them back into care. So that's from my perspective. I would love to see that from both social service, social work, but also from a medical standpoint with a nurse. Rosita, you've also had some similar concepts, haven't you?
Yes, we've thought about that, but I think the question is, and just let me clarify, are they speaking almost like the teledoc scenario?
I think so. In moving, you know, of course, currently the way you guys are set up from an infrastructure standpoint, you know, reaching patients in the clinic now currently is the business model. Have you considered maybe reaching out and going to the home, you know, via telemedicine? Yes,
we have. We are exploring that option as we speak about the possibility of a home-based sort of a telemedicine scenario.
As far as the technology piece goes, there are some amazing vendors out there that have the technology part that will support all of that, from vitals to just about everything you'd need for follow-up care. One of the obstacles that we face here in this state, which is really the reason that we haven't branched into that yet, is that the state doesn't reimburse for that. They do not consider it to be something that is an actual medical encounter. And so until some of those laws are looked at a little bit more in depth, being able to use the direct practice model that we utilize here at MAO, we actually can't do that. We are branching into in-home social work services, where when we go to do in-home visits or checkups on our patients, they're actually taking a tablet with them that will integrate with our telemedicine equipment. So if there is some sort of emergent need, we can assess the patient very quickly, or if they just need to have a few-minute conversation with a provider or a nurse, that isn't something that we would do billable. But as far as a billable encounter, right now the state of Alabama does not recognize in-home care.
But I love that concept, and I think actually it is a way to do it. And especially if you've got transportation barrier areas, if you've got more rural people, elders, et cetera, I really do believe that's a future. So my prayer is that will occur. Thank you.
The second question also came from Luke, and he's basically asking about how you guys are dealing or overcoming sustainability, some of the sustainability challenges that are associated with some of the recurring clinical software costs, such as, and I know you guys mentioned the stethoscope that you use, maybe some of your hardware-based codecs, and some of the ongoing license and agreements that come along with that. His question, I guess, is, have you guys considered in moving forward, have y'all looked at that, say, versus the possibility of maybe moving to something like a web-based platform or like a hosted solution?
Right. From our perspective, one of the benefits for us is because we're dealing with a very specialized care with our HIV specific, we do get assistance on federal grants from a program through HRSA called the Ron White Care Act. And that is a sort of that act and those funding streams always say they should be the biller of last resort. Certainly in a state like Alabama that has uninsured, that's been a big benefit to keep us going. In that, also the benefit is the Ron White Care Act actually does recognize telemed services as something that it will help to reimburse with, which is wonderful. So from that perspective, we're able to use some of those dollars to be able to enhance our programs, and some of the program income we can make off that, we can pull right back in, because we are a nonprofit, a 501c3, so we just push it right back in to our equipment scenarios. So for us, that's the option. As we expand, though, and it is a good question, for people who are not living with HIV, we cannot cover them by the Ron White Care Act dollars as that last resort. So that may be something from our perspective in that point, but also anybody who's not doing HIV care, that will be something that will have to be investigated more in depth. So that could be a future discussion for us, even more so.
And currently on the technology side, as far as the peripheral reoccurring expenses go, in our model, the only reoccurring expense that we have is the stethoscope licensing. And so as the competitors continue to develop better product, we feel pretty confident that pricing is going to become a little more aggressive than it is now. The issue that we run into is when we first started this project, the Littman stethoscope licensure was only $100 a year per end. They have now, because they consider themselves the only true player in the game to offer the solution that they offer, they're actually charging you $700 per end. So as more people continue to branch into telemedicine, as the demand becomes greater, and as the competitors out there actually develop product that is every bit as reliable as what we have come to use with the peripherals we use, we will see that pricing will become a lot more competitive and not be quite as daunting as it may be now.
Thank you, Lloyd.
Yep. Thank you guys very much. Well,
I appreciate it again. Thank you all. Thank you everybody who listened to our story and our history. And I hope we gave you a little bit of info that maybe somebody can use. And certainly they're welcome to contact us at any time. We'll have the slides and everything sent, and Becky's going to help us to get that on. And everybody feel free. And anybody wants to come visit us, they're welcome to come to Montgomery. We'd love to host you and feed you some good Southern food.
All right, you can see on the chat there, Miss Becky Sanders has posted the link for the survey that she had mentioned. So if you would please take an opportunity and fill that out. Everything will be posted out on the YouTube page as well. The next webinar series, we typically do these every third Thursday of the month, but due to the Thanksgiving holidays for November, that webinar will actually occur on November the 10th. And so so that you'll be receiving more information on that particular webinar, and that one is actually going to be hosted I think, Becky, it's the South Central Telehealth Resource Center, and Dee Pratt it's going to be Transforming Medical Nutrition. via telehealth, and D. Pratt will actually be heading that particular one up. So anything else, Becky, that you may have before we close out?
No, I think that's it. Encourage folks, please go ahead and fill out that survey. It's just a few questions. Take a minute or two of your time. It helps us as we look at future programs and topics of interest.
Yeah. Thank you, Michael and Rosetta, very much for giving us your time today on behalf of the Southeastern Telehealth Resource Center. We appreciate the partnership that we have with you. And on behalf of all the telehealth resource centers, thank you for making this webinar happen today.
Thanks, everyone.